So now we will continue with the part 3 of the local anesthetics. As we have discussed the part 1 and part 2, so now we will continue with the part 3. So now we move to the next slide. Now in this slide we will discuss about the mechanism of action of local anesthetics. Now there are basically three different theories regarding the mechanism of action of local anesthetics. First of all, the most accepted theory is the voltage gated sodium channel blockers, or the membrane stabilizing effect, which states that the local anesthetics are voltage gated sodium channel blockers. In the view of this theory, it states that the local anesthetics enters the axonal membrane, and it blocks the sodium channel that is present within the axonal membrane from the inside, and do not allow the entry of sodium from outside to the inside of the nerve terminal or the nerve trunks. As we know that sodium is required for the depolarization of the neurons or nerves. Therefore, when the sodium channels are blocked, so the nerves will not be able to enter the nerves or the nerve trunks, and there will be no action potential. And when there will be no action potential, so there will be no excitation of the nerves and no propagation of the nerve impulse across the nerves or nerve trunk. The second theory that was put forward in the early stages of the local anesthetics mechanism of action was that the acetylcholine has a dual role. First of all, it acts as a neurotransmitter within the neuromuscular junction, and secondly, it also has some role in the nerve conduction. But this theory was rejected because there was no role of acetylcholine was found in the propagation or propagation of nerve impulse across the nerve or nerve trunks, and there was no acetylcholine was found in the nerve conduction process. This was about the two theories. In the next, now we move to the next slide. In the upcoming slide, we will discuss about the third theory that was also put forwarded about the mechanism of action of local anesthetics. So now in this slide we will continue the mechanism of action of local anesthetics, and we will discuss about the third theory that was put forwarded in the early stages of the mechanism of action of local anesthetics. The calcium displacement theory. This is the third theory that was put forwarded, and the calcium displacement theory states that local anesthetics cause a displacement of calcium ion from a part of the nerve membrane site that controlled sodium permeability. It means that the local anesthetic caused the displacement of the calcium ions from the nerve membrane, and after displacement of the calcium ions, it states that the calcium ions were necessary for the sodium permeability, or the calcium and the sodium were necessary for the influx of sodium from outside of the nerve membrane towards the inside of the axonal membrane. So as the local anesthetics displaces the calcium from the membrane site, so the sodium permeability cannot occur. But this theory was also rejected because no such site was found on the nerve membrane where calcium was present, or where the displacement of calcium could occur, and only the theory that was put forwarded later, that is the membrane stabilizing theory, or the voltage gated sodium channel blocker theory, seems to be true in this case. Which will be discussed diagrammatically in the upcoming slide. Now in this slide you can see the diagrammatic representation of the blockade of sodium channels by the local anesthetics. You can see that there is a sodium channel that is traversing the axonal membrane from outside towards the inside. Now the local anesthetics, when they are given through any route, they are absorbed within the axonal membrane, as they are absorbable within the axonal membrane, and after its entry into the axonal membrane or coming into the intracellular area, they act upon the sodium channels from the inside and block them from the inside. So when the sodium channels are blocked by local anesthetics within the sodium channels, because they bind with the specific receptors that is present on the inside of the sodium channels. So after the blockade of the sodium channels, the sodium influx cannot occur from the outside of the extracellular area to the inside of the intracellular area. As we know that sodium must be required, is necessary for the propagation or for the stimulation of the axonal membrane and for the production of the action potential. So when there will be no entry of sodium from the outside to the inside, there will be no action potential, and there will be no excitation of the axonal membrane, and there will be no propagation of the nerve impulse across the axonal membrane. So this theory is the most accepted one, and seems to be the most practical one. So now we move to the next slide. Now in this slide we will discuss about the clinical uses of the different local anesthetics. The different local anesthetics can be used in for the following conditions. Number one is the infiltration anesthesia. Number two is the regional block, and number three is the surface anesthesia. In number one, in infiltration anesthesia, local anesthetic is injected locally into the skin or mucosa, causing loss of sensations by paralysis of the local nerve fibers. So this type of anesthesia is called infiltration anesthesia. In second condition, the second use is called the regional block. It is the regional block is a specific part of the body. In the regional block, a specific part of the body is anesthetized, and the regional block can be of the following four types. Number one can be nerve block. Number two can be intravenous block. Number three is the extradural block or the epidural block, and number four is a spinal block. Now we will discuss one by one about the nerve block, the different types of the regional block. Number one is the nerve block. In the nerve block, the local anesthetic is injected near nerve, or the injection should be made directly into the nerve. This will cause anesthesia in the area of supply of that particular nerve. For example, facial nerve block, pudendal nerve block, paravertebral block, or brachial plexus block, etc. So this was about the nerve block. And then number two, that is the intravenous block. Intravenous block is a type of renal block in which the local anesthetic is injected into a vein of a limb after applying a double cuff proximal to the area of injection. In intravenous block, anesthesia of the limb will occur in 6 to 8 minutes and will last for about 30 to 40 minutes. The cuff is deflated 20 minutes after the procedure. Now, during the intravenous block, care should be taken to prevent the absorption of drug into the systemic circulation that can lead to the serious toxicity. Some absorption of drug can also occur through the blood vessels of bone that cannot be occluded by the cuff. So intravenous, this was about the intravenous block. Now the third type of regional block. In the third type of regional block is the extradural or epidural block. The local anesthetic is injected into the thoracic, lumbar, or sacral area of the vertebral column in the extradural space. This will cause paralysis of the nerve roots. This technique is usually employed in obstetrical procedures. So this was about the extradural block, and now we will discuss about the spinal block, which is also called the subarachnoid block or subarachnoid anesthesia. In this type of regional block, The local anesthetic is injected into the subarachnoid space of the spinal cord. This will cause a paralysis of the spinal roots. Paralysis of sympathetic nervous system can cause hypotension. Therefore, care should be taken while induction of spinal anesthesia. This technique can be used for various abdominal and obstetrical surgical procedures. Aseptic precautionary measures should be taken to avoid the introduction of microorganism into the CSF, because we are directly approaching the subarachnoid or the spinal space. Therefore, care should be taken not to introduce the microorganism into the CSF. This was about the infiltration anesthesia and the regional block, and how the local anesthetics are used for the induction of infiltration anesthesia and the regional block. And we have also discussed about the four types of the regional block. Now we will move to the next slide. Now in this slide we will continue with the clinical uses of the local anesthetics, and the third condition in which the local anesthetics can be used is for the induction of surface anesthesia. For the induction of surface anesthesia, cocaine, lignocaine and prilocaine can be used locally on the skin and mucous membrane to produce the surface anesthesia. For example, the cocaine can be used for the induction of surface anesthesia to undergo the nasal surgery. Now, there is another use of the local anesthetics, that is the eutectic mixture. What is eutectic mixture? Eutectic mixture is basically a mixture of crystals of lignocaine and prilocaine, and they are thoroughly mixed together, and when they dissolve into each another, then this mixture is called eutectic mixture. This mixture can be used locally on the skin to produce anesthesia for the purpose of acupuncture or venipuncture, especially in the children. So up till now we have discussed about the different clinical uses of the local anesthetics. First of all, we can use the local anesthetics for the infiltration anesthesia. Then we can use the local anesthetics for the regional block. Then we can use the local anesthetics for the induction of the surface anesthesia. Then a mixture can be made from by combining the two local anesthetics, the lignocaine and prilocaine, which is called eutectic mixture, and this mixture can be used for the purpose of acupuncture or venipuncture in children. So this was about the clinical uses of the local anesthetics. Now we move to the next. Now in this slide we will discuss about the combination of local anesthetics along with other drugs. The local anesthetics can be combined along with two different drugs. Number one is the adrenaline and noradrenaline, and number two is the felipressine. Now, first of all, we'll discuss about the first combination, that is adrenaline and noradrenaline in combination with local anesthetics. Now, as we know that adrenaline and noradrenaline are basically vasoconstrictors, and when they are combined with local anesthetics like esters or amides, then after injecting into a specific site, the adrenaline brings about the vasoconstriction, and in this way the local anesthetics do not escape from the blood, do not escape into the blood vessels, and do not mix up with the local circulation, and remains for a longer period of time within the tissue. And in this way, this combination, that is adrenaline and noradrenaline, with the local anesthetics, is used to prolong the duration of anesthesia. Now the second combination can be with the felipressine. It is the felipressine along with the local anesthetics, that is the esters or amides, when combined with the local anesthetic in case of cardiovascular patients. Adrenaline and noradrenaline along with the local anesthetics can be used for the prolongation of the anesthesia in cases in whom there is no cardiovascular issues. Whereas if there are cardiovascular issues in patients, so we do not add adrenaline or noradrenaline to that local anesthetics for induction of local anesthesia. In this we add felipressine with the local anesthetics in cases of cardiovascular patients. How much will be the quantity of adrenaline, or what will be the ratio of adrenaline and noradrenaline in combination with the local anesthetics? So adrenaline for prolongation of local anesthetic effect can be used in a concentration of 1:2 lakh or 1:4 lakhs. This ratio should be remembered because is often asked, and it should be remembered by heart. So this was about the combination of local anesthetic along with the adrenaline and noradrenaline, and along with the felipressine. So now we will move to the now with this we came to the conclusion of part 3 of the local anesthetics. Now we will move to the part 4 of the local anesthetics. So stay tuned for the part 4 of the local anesthetics.